I'm Liz Cohen. I'm Dean here at the Radcliffe Institute for Advanced Study, and I'm delighted to welcome all of you. And I'm especially pleased to welcome Dr. Doris Taylor, who's the Director of Regenerative Medicine Research at the Texas Heart Institute. And she'll be delivering the annual Dean's Science Lecture today. At the Radcliffe Institute for Advanced Study, scholars, scientists, and artists work at the forefront of their own fields and across disciplines. We are dedicated to fostering and sharing with the public innovative work in all subjects, but we are particularly proud of our strong tradition in the sciences. That tradition harkens back to Mary Ingram Bunting, the microbiologist and 5th president of Radcliffe College, who founded our forerunner, the Radcliffe Institute for Independent Study, which eventually was renamed in her honor the Bunting Institute. This tradition has manifested itself in several exciting ways already this academic year, beginning with a conference we hosted at the beginning of the fall term on women in the biotech industry. We also held a symposium on the past, present, and future of DNA. And if you missed either of these two great days, be sure to check out the videos on our Radcliffe Institute website. Many of you might also be interested in a 2014 conference that we entitled Who Decides? Gender, Medicine, and the Public's Health, because several of its panels overlapped with the subjects of today's lecture. And you can see a full video of that conference on our website as well. Every year, the Dean's Lecture in the Sciences is a major occasion. Last year, Dr. David Montgomery, a geologist, electrified us with his look at how floods have transformed planet Earth over the millennia. In another year, Dr. Lawrence Krauss, a theoretical physicist, considered the entire universe before time even began. This year, our lecture topic moves in a different but equally infinite and mysterious direction: inside human beings. Dr. Doris Taylor studies disease and healing at the cellular, genetic, and molecular levels. In addition to serving as Director of Regenerative Medicine Research at the Texas Heart Institute, she teaches at Texas A&M, and she has co-authored or authored more than 80 scientific publications. She holds positions on numerous advisory boards, think tanks, and editorial boards. She has consulted with the FDA, the Department of Health and Human Services, and other government agencies. Locally, her work is well known at the Harvard Stem Cell Institute, the Connors Center for Women's Health and Gender Biology, and Brigham and Women's Hospital. She frequently appears as an expert for NPR, CNN, the New York Times, the BBC, and a host of other media outlets. Much of Dr. Taylor's work has focused on the potential of stem cells to regenerate organs and to treat illness, including heart disease. Heart disease, not cancer, not infectious disease, but heart disease, is the leading cause of death for both men and women in the United States and worldwide. In Taylor's lab, she and her team are pioneering a revolutionary alternative to heart transplant as the remedy for a failing heart. They are literally inventing a way to grow a fully functioning new heart from a patient's own stem cells. Of particular importance, Dr. Taylor has discovered significant sex differences in stem cells and in organ structure. Stem cells harvested from female humans and other animals tend to be hardier and more potent than stem cells from males. Moreover, Taylor has shown that the cellular structure of several vital organs, including the heart, is stronger in females. Now, to many of us here, this knowledge that women are stronger than men comes as no surprise. But the scientific proof is certainly nice to have. As Dr. Taylor herself said to the Pittsburgh Post-Gazette, and I quote her, "We always knew women were awesome. Now we have the science to back it up." Joking aside, there are serious implications to these sex differences. Women might have structurally stronger hearts, but when those hearts start ailing, the symptoms look different. As a result, disease escapes detection, and if women do have heart attacks, they are more likely to die from them than men, partly because of the disease's advanced progression. Yet most studies of heart disease focus on men, and men heavily outnumber women in most clinical trials for new therapies. Some of that skewing is about to change, thanks in part to discoveries like Dr. Taylor's. As of this year, the National Institute for Health Guidelines requires researchers applying for grants to consider sex as a biological variable. That means that in order to receive funding from the NIH, researchers will need to look at male and female cells and organisms. Radcliffe has been supporting the study of these differences from multidisciplinary angles for some time now. Not so long ago, Radcliffe's faculty director in the natural sciences, Janet Rich Edwards, collaborated with a group of scholars and clinicians to convene a seminar titled Unexplored Sex Differences in Cardiovascular Disease. One of the collaborators was Dr. Paula Johnson of the Connors Center for Women's Health and Gender Biology at Brigham and Women's. Paula is a renowned cardiologist, director of the Connors Center, and a valued member of the Radcliffe Institute community. Dr. Taylor's discoveries about sex differences in cells, discoveries with big public policy implications, speak directly to Radcliffe's twin interests in gender and science. As I mentioned a moment ago, we began this academic year with a conference on women in biotech, a field where being female appears to impede women's success. Yet Dr. Taylor's work tells us that in other ways, like stem cell vitality and organ structure, sex differences actually favor women. That contrast leads us to a fascinating paradox. Gender, which is socially constructed, can hold women back, but sex, biologically determined, does not. The Radcliffe Institute is a perfect place to wrestle with this paradox. Dr. Taylor's expertise can enable us to do so by helping us to understand the science. So please join me in welcoming to the Radcliffe Institute Dr. Doris Taylor.
It's a real pleasure to be here, and it's a real pleasure to have the opportunity to talk a little bit about some of the science that you've heard about. And I have to say I'm a little envious that you're going to get to hear about forensic DNA and other DNA lectures in the next month. That's pretty darn exciting, and I wish I were going to be here. Now, let me, however, say that my bias is DNA is the potential and cells are the reality. So I want to tell you about why I think cell therapy is important. I want to raise some questions and some controversy because many of you may or may not know that cell therapy, there's a big call clinically, or there's a big call from a number of basic scientists to halt cell therapy clinical trials in the cardiovascular field. And we'll come back to that, but one of the reasons for that is because scientific funding is at the lowest it's been in my lifetime. And when there's a limited amount of money to go around, there's an increase in the competition for that. So I'm hoping I can convince you that moving forward clinically is worth it because science is really about making a difference in the lives of people, at least in my opinion. I'm the person who gets to stand here and talk, and yet these are the people who are in the trenches every day, and all of you who are educators know, and all of you who are students know, you're the ones doing the work, we're the ones talking about it, and I'm just grateful that I have an amazing group. But I also have an amazing mentor, Jim Willerson, who's standing there next to me, who is one of the best cardiologists around, 76 years old, spends 6 days a week, 7 days a week at the hospital, only superseded by Denton Cooley, who started the Heart Institute, who's 92 years old and is still there 3 days a week and lectures on those 3 days when he's there. So while we women may have superior stem cells, those guys in Texas have something, I gotta tell you. So I really want to try to convince you today that aging is really a failure of stem cells, and that regenerative medicine is a real solution to cardiovascular disease if we choose the right targets. And men and women are different, and maybe the treatment should be as well. It's really not complicated. Aging is a failure of stem cells. Why do I say that? I say that because if you think about it, you know this, if you think about it, for most of your life, endogenous repair, normal wear and tear on your organs and tissues occurs. But you repair those organs and tissues. And because you have stem cells in virtually every organ or tissue and in your bone marrow that can do that. Now let me back up and say, to make sure we're all on the same page, what's a stem cell? A stem cell is really very simple. It's a cell that can do two things. It can make more of itself, self-renew, and it can differentiate into a number of different organs and tissues. And I apologize for bringing coals to Newcastle here, talking about stem cells to people at Harvard. But it's important that we're all on the same page. If you think about it even further, when you're 2 years old and you injure yourself, fall down and scrape your knee, you don't have a scar. It heals within a few days. And you don't have a scar for the rest of your life unless it's a really severe injury. And that's in part because your organs and tissues can regenerate, not just repair at that stage, because you have stem cells that are there and are potent. But when you're 62 and you fall down and you scrape your knee, not only does it take more than a couple of days to get better, it takes weeks, and you may have a scar forever because you've used a lot of cells over those 60 years, repairing your organs and tissues on a daily basis. Furthermore, not only is endogenous repair the norm, but injury is essential. When injury happens, there's a response to that injury. When you scrape your knee, your skin turns red. It swells. There's inflammation. And inflammation, in my simple worldview, with all due apology to the people in the crowd who think about inflammation all day, every day, inflammation is basically nature's cue to say, send me cells. I have an injury, send me cells. And if you get the right cells there, you turn off that inflammatory response. But if you don't, so acute inflammation is good. But if you don't turn off that inflammatory response or don't get the right cells, your body ramps up inflammation and says, I said I have an injury, send me cells. And then you start recruiting pro-inflammatory cells, and you actually exacerbate the injury. Well, that's all great, except that I just told you that with aging and chronic disease, the number of reparative cells we have goes down, and the potency of the remaining cells we have decreases. So what does that mean? It means that ironically, nature's kind of ironic, at the times we need it in our life, 60s, 70s, the number of reparative cells we have aren't there, and we can't actually use the ones we have very well. So a number of us, almost 20 years ago now, said, let's develop exogenous therapies where we can take stem cells and deliver them where they're needed after an injury, so that we can increase stem cell number, we can increase stem cell function and potency, but we can recognize that we're putting those cells into a stressful environment. And so we're going to have to increase their survival under stress. But none of us want to say, the good news is we transplant cells in your heart and you no longer have a heart attack, but now you have a tumor. We want to control cell proliferation. So the balance is getting cells where we need them, when we need them, but controlling those cells. So there are a lot of theories about aging, and I'm not going to spend a lot of time on these, except for the very last one, to say each of us know that there are these things called telomeres, the ends of our chromosomes, a piece of DNA. And those telomeres are essentially pieces of DNA that shorten every time our cells divide. And the Nobel Prize was given for the discovery that not only do these pieces of DNA shorten with each cell division, but essentially that as those pieces of DNA get short enough, our cells say, oh, I must be old, it's time to die. So then those cells die. However, another important piece of information is that as telomeres shorten, the cell division that I told you is a characteristic of stem cells slows or stops. Again, the stem cell numbers in bone marrow decline, and the endothelial linings of our blood vessels begin to get stiffer. The real pain in the neck of it all is that telomeres also shorten with stress. Stress is another word for, in my worldview, inflammation. And if you think stress doesn't accelerate aging, I have one thing to say. I think it does. That in fact, the data are pretty robust that as you're subject to stress, you age. So how does that fit with cardiovascular disease? Well, cardiovascular disease is progressive. Atherosclerosis, one of the first steps in ischemic heart disease, increases with age and increases with risk factors and other comorbidities. Those things that suck up some of our stem cells because there are other hits, those risk factors and comorbidities. And as cardiovascular disease progresses, and as aging progresses, aging contributes to a decline in cardiovascular health. We all know the aging process differs to some degree in men and women, and I'll come back to that. And the onset and progression of cardiovascular disease is different in men and women. In men, cardiovascular disease starts younger but levels off. In women, starts slower, but women catch up with men by the 7th decade, by our 70s. And both aging and cardiovascular disease, as I've said, are associated with decreases in stem cell number and function. And these stem cell numbers are different in men and women's bone marrow. Now here's what the onset of atherosclerosis looks like in males and in females. Now this happens to be an animal model, a mouse model, but the same curves are identical curves for men and women, human men and women. So if you look at the amount of plaque that occurs in your aorta, in males, it increases, levels off. In females, it starts slower. Well, okay, that's fine. We all get sicker as we age. But what's equally interesting is if you look at stem cells in the bone marrow, look at how those change over exactly the same time frame. They decrease. And they decrease in both men and women. So we ask the question, well, if we replenish stem cells in men and women, can we actually prevent the onset and progression of cardiovascular disease? In other words, can we intervene? So I'm going to talk about giving cells into injured vasculature intravenously. All we did was take bone marrow cells and deliver them IV 6 times, once every 2 weeks, to animals that would normally go on and develop atherosclerosis. So this is an animal, this is the aorta of an animal, and see all this fat here? That's essentially plaque. And if we slice this blood vessel and look, you can see there's a huge amount, actually slice this blood vessel and look, you can see there's a huge amount of gunk. That would be the scientific term. The atherosclerosis in this blood vessel leading to the head. And even in the aorta at the level of the heart. So all we did is we took animals and we fed them what we would normally call, I did this experiment while I was at Duke, and we called it the Duke student diet, a high-fat diet, basically, hamburger equivalent, every day. But we gave the animal cells every 2 weeks. And we said, okay, let's see what happens. Well, I wouldn't be talking about it if it weren't interesting, but look at this. In the animals that we treated with cells, just IV, we could show that we could prevent plaque formation. And interestingly, we could also decrease inflammation when plaque went down in the blood vessel, in the blood, and we changed no cholesterol levels, no lipid levels. We didn't change their diet. The only thing we did was give them cells IV. Now, most of us probably, that's great, we can prevent plaque, but most of us aren't 18. We probably don't want to take cells for the rest of our lives. The real question was, could we regress plaque? Could we take animals that already had all of this plaque in their vessels and treat them with cells and see if the plaque went away? And we did that in this was, you know, it's funny how life happens. Sometimes you think that you're, in fact, doing science for the sake of answering a question, and you find it leads you in a completely different direction. We did an experiment where we wanted to track the cells we delivered. So we gave male cells to female animals, because we could track the Y chromosome, okay? And we'd say, did the cells we delivered make any difference or not? And what we found is the cells had no effect. And then I went, okay, now I guess we have to give female cells to male animals and try a different way of tracking this. And what we found is that when we took animals that had this degree of plaque, male cells, and we gave male animals and we gave female cells, we could actually reverse plaque formation, but only if we gave female cells. And in fact, what we found is that the male cells not only had no effect, there was a trend towards worsening atherosclerosis in the females. And the female cells could reverse plaque, but only in males. Okay? Nature fought back. So all of a sudden, I found myself saying, wow, wonder if anybody's ever really looked at the difference in cells in the bone marrow of men and women. And this was back in 2003, 2004, and nobody had. So what we did is we basically said, let's start looking. And sure enough, as we started looking at normal men and women from age 20 to age 80, and that this is just a small number of the individuals we've looked at, and we looked at a number of different bone marrow-derived cells, what we found is that these cell numbers, these progenitor cells, decreased in males with aging, but they didn't decrease in females. And if we looked at inflammatory cells, they tended to stay stable in females, and they tended to go up in males. No comment. And moreover, if we looked at these circulating cells in women versus men, and we looked in healthy individuals or individuals with disease, what we found is that these cells went down to a greater degree in men than in women in response to the disease. So not only did they start out with fewer cells, but as soon as there was any indication of disease, the number of cells took a bigger hit in males. My reaction to that was, you guys are toast, but really it made me stop and ask the question, is anybody really looking at this? So not only did we find that specific cell populations were much lower in males, but the signal for recruiting these cells out of the bone marrow into the bloodstream was lower in males than in females. So fewer cells, less signal, and less and a bigger hit when the injury occurs. And it made me ask the question, does this matter clinically? And about the same time, we were moving forward with cell therapy trials. And cell therapy is based on the assumption that you can harvest cells, that they're present, they're capable of responding to the injury and mediating repair. But if cells are decreased with disease, and more so in males, and the signal for recruiting cells, it could actually be drive increases in pro-inflammatory cells, and there are less of these cells, maybe we shouldn't be doing cell therapy in males. Or maybe we shouldn't be using autologous cells, your own cells, if we were going to go forward. But at the same time, nobody was asking what are the clinical implications. And so I'm going to take you up to where we are now, which is if you go to clinicaltrials.gov and you look at cardiovascular cell therapy studies, there are 550 studies listed. About 200 of those are open studies. And there's small improvements in heart function, 3 to 5% improvements in ejection fraction, minimal benefit. But all the studies have been conducted primarily in men over the age of 60 using autologous cells. And I just showed you, looking at a number of different data points, that bone marrow differs between individuals. So if I looked at your bone marrow and I looked at your bone marrow, it'd be different. So not only are we doing these in men over the age of 60 using autologous cells, every single individual in the trial is getting a different drug. That's like doing a clinical trial where you say, let's give a drug, but let's give this pill. But oh, by the way, we aren't really sure what's in this pill, and we aren't really sure if it's the drug or not. We don't know how much is there, and we really aren't sure if there are negative things in here or not, but let's give it anyway, and then let's look for an outcome. So that's how the cell therapy field has gone forward. So about 8 years ago, I said, okay, I want to form a biobank where we take the product from every person who's getting cell therapy, and we actually characterize not only what cells are there, but what affect the different cell populations, what different cell populations associate with positive or negative outcomes. And remember I talked to you about aging? Well, sure enough, as we began to do that, what we found is that if we look in cell therapy trials and you use, for heart disease, and you use ejection fraction as a baseline of improved heart functional capacity, that if we looked in individuals overall, there was a 3 to 5% improvement in ejection fraction, irrespective of age. But if we separated this by age and looked at people under the age of 62 and people over the age of 62, all of a sudden, the effect on ejection fraction was much greater. Now, I will point out that this is men and women combined because my colleagues don't want to separate the data by sex. Why don't they want to separate the data by sex? Because the study's not powered to detect a difference in sex. What does that mean? Well, that's, Dr. Rich Edwards can tell you that's a statistician's way of saying you didn't recruit enough women. And at the same time, what it really means is because we're not reporting data by sex, even though we didn't recruit enough women into the study, we'll never be able to aggregate data in a way that lets us tell if there are differences between men and women. So hopefully one of the things that's going to happen going forward is we also have to report our data by sex. At the same time, one of the things I said is let's look at a negative study where people got better. And it's a small study, admittedly. There were only 80-some people in the whole study. But there were a few patients who actually got better in every parameter of heart function that we looked at. Ejection fraction, end-systolic volume, and VO2 max. Again, men and women combined. And then there were patients who got worse in these endpoints. And I said, let's compare the people who got better in all three with the people who got worse in all three and see if any particular cell populations come out. Now let me remind you that the cell therapy that was being used is your bone marrow. So we were deriving cells from your bone marrow, getting rid of the red blood cells, and then transplanting that into your heart. Okay? Now, for those of you who know about bone marrow transplant, you know that that's been happening for 60 years. Bone marrow transplant's not a new thing. What's different about cell therapy is we're not wiping out your bone marrow with drugs before we give you cells back. We're giving you your own cells back, but at the same time, we're giving you bone marrow, which is a heterogeneous population of cells, okay? And 3% of those cells are stem or progenitor cells. that means 97% are not. And yet, all of us who are doing cell therapy think those 3% of the cells are the ones that are going to be important. Turns out that examining the cells that mattered, and all these markers don't matter except to say that the cells that matter are not progenitor cells. They're immune cells, B cells and T cells are the cells that predict whether or not you do better in cardiovascular cell therapy trials. So all of a sudden, what we've done is we've said, wow, everyone's getting a different drug. There's some degree of improvement, but the cells that matter aren't stem cells. So should clinical investigations of cell therapy go forward? Well, I happen to think they should if we're thinking about the questions in the right way. And the reason I think they should is because we have the opportunity to choose new and better cells and to actually say, what if we got rid of the negative cells in bone marrow? Or what if we enriched for the positive cells? Or even more, what if we actually started looking at some of the more recent cell populations, heart-derived stem cells, or even embryonic stem cells, or induced pluripotent stem cells. But there's a big debate in the field about whether cell therapy should continue, and I want to do one thing historically and say, let's compare it to other treatments, because I don't want you to walk away from here saying cell therapy is a negative. The first attempt to use fibrinolytic therapy, clot-busting drugs to treat a heart attack, happened in 1959. Clot-busting drugs are standard of care right now in a heart attack because the sooner we can get your blood vessels open, the sooner the more likely you are to survive and do well after a heart attack. First attempt to use them was in 1959. 20 years later, there was a paper published in 1979 that basically said, 20 years later, the value of thrombolytic treatment in AMI is not established. We need to do new trials with prolonged follow-up and precise and multifaceted controls. They seem justified. I would argue that's where we are in cell therapy. We started out in 1998, my group was the first group to transplant cells in the heart. And I'm going to talk as much about politics as I am about science for a minute. 1998, my group was the first group to transplant cells in the heart and show we could improve function in the heart after a heart attack in an animal model. 1998, no one had ever done that before. Within 12 months, the first patient was treated in Europe. Within 12 months. What that means is, despite the fact that some of us were saying, we don't know the right dose, we don't know the right cell, we don't know the right patients, we don't know the right anything, this is going forward. And it was sexy. It was a time when healthcare dollars were tanking, and there was a huge emphasis on being first and best. So a lot of people jumped on the cell therapy bandwagon. What that meant is that rather than answering those questions in the laboratory, we tried to answer them in people. And 18 years later, we're still asking, what's the right cell? What's the right dose? What's the right delivery method? And oh, by the way, do we even know which cells matter? So for those of you who are students or fellows, it's critical that you think about the fact that just because you hear about a new therapy doesn't mean it should happen tomorrow. It really should be vetted first. But if we look at another drug, beta blockers, that's actually a drug that's changed the lives of people with heart failure. Used to be that beta blockers were absolutely a no-no in heart failure. No, you're going to kill everybody if you give them a beta blocker. And then some of my colleagues at Duke, I'll never forget this, we were having a conversation about whether or not it was going to be cost effective to do a clinical trial with these drugs. And some of my colleagues at Duke said, well, it's never cost effective to do a clinical trial. It's cheaper if everyone just dies. So then we said, okay, yeah, that's true, and I've never forgotten that the cheapest clinical trial is the one where everyone dies. But somebody took that courageous step and said, let's go forward with the beta blocker trial. And now, beta blockers are given all day, every day for heart failure. And the improvements in ejection fraction are 5 or 6 or 7%. The same numbers we're getting for cell therapy, but we're not moving forward with cell therapy. What turned out to be equally interesting is that when you look at beta blockers, and this is a study from 2012, and I just want to make the point again. If you look at another study with beta blockers, where they evaluated ejection fraction in patients with heart failure, almost 4,000 patients. Ejection fraction increased about 6.4%. This was just a historic search of the literature. Age, race, and practice setting were similar between the individuals who improved more than 10% or those who did not. But female sex, no prior heart attack, and a couple of other parameters were associated with not a 5%, not a 6%, but a greater than 10% improvement in ejection fraction. I hadn't heard about this paper and how women do better, and how being a woman means you can recover dramatically from your heart failure. We just kind of throw those things aside, and I think it's critical that we not. But if we do a meta-analysis of all the cell therapy trials, what we do know is that administration of adult cells is safe. It produces a sustained greater than 12-month improvement, not necessarily in heart function, but in survival, in rate of rehospitalization, and in quality of life and exercise capacity. But we still don't know the best cell, the best dose, the best route of administration, or even whether we should give cells more than once. Not to mention what happens to women enrolled in the trials. So what can we do about that? Well, I'm going to move forward quickly because I want to show you that what I believe we can do is repair the cells, select more potent cells, pick better patients, maybe use cells that aren't derived from us, or we can just say, the heck with it all, let's go home. Let's have that glass of wine. One thing we've chosen to do is to say, let's take old stem cells and try to rejuvenate them and make them young again. So we're actually taking cells from old mice and old people, and we're taking that telomere and treating it with an enzyme that makes the DNA longer again. And when we do that, we can actually make these cells think they're young again. And then we're putting them into a stressful environment and showing that if those cells that we actually treat actually can have a positive effect after a heart attack. I'm not going to spend a lot of time on this because what I really think is more important is picking better patients. And here's one suggestion. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects has just never occurred to anybody. Maybe we should be doing some of these clinical trials in women. Statistics tell us that heart disease kills just as many women as it does men, killing 1 woman a minute. 90% of women have one or more risk factors for heart disease, and since 1984, more women have died each year from heart disease, and that gap continues to widen. But women are not well represented in clinical research. They're less likely to enroll, and they're more likely to drop out, citing family concerns. And less than 10% of all clinical trials report results for men versus women. But what's being reported is that the number of women in clinical trials is increasing. That's true if you consider women-only trials, but only if you consider women-only trials. So NIH has set these goals for 2020 to increase sex differences research, both basic and clinical, to incorporate findings of sex and gender in the design and application of all these technologies, to really recognize that they have to work with partners. And in fact, the FDA is coming out with their own women's roadmap on February 18th, and I look forward to that. For inclusion of women in approval of drugs and clinical studies, and to develop and implement new strategies to increase women's enrollment in clinical trials. But it doesn't just make sense, it's good science. We isolated stem cells from the heart of males and females, from biopsies from the heart. And if you look at these data right here, you can see that the most potent stem cells that are being used, as a population called SSEA1 positive cells, c-KIT positive cells, 2 other FLIC1, doesn't matter. In every case, the red bar is females. There are 4 times as many stem cells in the heart of women than men. And yet, nobody's looking. So we need to think about whether we're choosing the right cells, and maybe we ought to be deriving some of these cells from healthy young women. More than that, we need to think about new interventions for getting our own stem cells moving. My favorite way of improving stem cells is, a good glass of red wine. But we also ought to consider if stress ages our cells, maybe some of these other things protect our cells. So we're in the middle of a clinical trial right now called the PROPEL study, where we actually look at progenitor cell release plus exercise to improve heart failure or improve atherosclerosis outcome in patients with peripheral vascular disease. And what we believe is that the people who exercise will increase the number of stem cells in the circulation and actually have an improved outcome. And our first preliminary data suggests this is true. Moreover, I did a clinical trial with Noel Berry-Mers, and it was a very small number of patients, but last year we published a paper showing that in women with heart disease, if we do acupuncture, we dramatically increase the number of these stem cells in the circulation. So all those things we've been told our whole lives about stress is bad, it's bad for your heart, and exercise and meditation and all these things are good for your heart, guess what? They mobilize stem cells. I was lucky enough to do a couple of experiments where I got to draw blood from Tibetan monks who work with the Dalai Lama. And I drew blood. Now, it's a very small n, like 6, right? But I drew blood 15 before and 15 minutes after they meditated, okay? The number of circulating CD34 cells went up 45% in 15 minutes when they meditated on the word compassion. I can't explain it, But I can tell you that someone who did MRI, functional MRI, during that same time showed there were dramatic changes in vascular flow to the head during that same period of time. So biology, it's all connected, it's all happening. Okay, it's also possible that maybe the answer's already there. We just need to look at old data in new ways. You know, just this month, there's a new paper out from some of our colleagues, Nanette Winger and others, looking at acute heart attack in women. And it's a scientific statement from the American Heart Association. And it basically is a comprehensive review of sex differences in the way women present with heart disease, the mechanisms, and their outcomes. Well, for years, we've known women have atypical symptoms when they present with a heart attack. But we've always just said, yeah, women are different. Maybe we need to do some deeper drilling and say, what does this tell us about mechanism in men and women? Because if we understand how we differ, then we can understand how to choose the maximal therapy for each of us. So a couple more points. I also believe that we can't ignore environment. You know, one of the criteria of a cell being a stem cell is you transplant it in a certain place and it responds to its environment and becomes like the cells around it. I call this a real estate approach to cell therapy. We can't ignore the environment. So typically we've said, let's take cells that are sensitive to ischemia, heart cells. What causes a heart attack in the first place? The blood supply in a blood vessel is blocked. The cells downstream don't get oxygen, so they die. And we've said, let's take new heart cells and transplant them into a scarred environment where there are no blood vessels and see if they work. Really kind of stupid when you think about it. But we've said we need to think about the environment. And then if we're going to put cells into an environment, we need to think about the cells. We need to think about whether or not we're putting them in a scar, really stiff, tough region, or whether they're going to have a blood supply, vasculature. Without all three, we're never going to get muscle cells to mature, and we're not going to get regeneration. And if you look at cells, they align with the fibers of the heart. One of the coolest things about the heart is that when you look at a heart, you know, we always say football good, basketball bad. One of the coolest things about the heart is it's shaped kind of like a football. And when it contracts, it rings. It essentially squeezes the blood out. And if it looks like a basketball, it's doing this, and no blood is going anywhere. And a failing heart looks like this, okay? Well, the coolest thing is that the fibers in the heart rotate as they go through the wall of the heart so that you can get that squeezing motion. But a scar doesn't look like that. A scar looks like just one layer of stiff leather. And I don't know how many of you deal with leather, but you can't pull it very much. And what that means is that the rest of the heart has to work a lot harder to try to contract when you've got a thin, leathery scar. So if you look here at a scarred region of the heart, here's a slice of a heart, normal slice of a heart. Here's a scar. Thin, leathery, but normal heart, if you take a normal heart, it's got all these muscle fibers. And what we did is we figured out that if we can get rid of the cells in the heart and leave this leftover protein that's underneath all these cells, it looks like the heart where we basically took a tube of toothpaste and squeezed out all the cells, rather than this thin, leathery region that's not organized in any interesting way. Why does that matter? It matters because if we take that piece of heart that looks like normal heart and we transplant it on the surface of a heart that's had a heart attack, so here's a region that we transplanted as a cardiac patch 7 days after a heart attack in an animal. Here's what happens in the animals normally. They get worse. Here's what happens if we put a patch on. The function of the heart stabilizes. Furthermore, if we look at that patch on the surface of the heart, new blood vessels grow into this patch, and stem cells, see these blue dots here? Those are the nucleus of cells. This red is the normal heart. This clear region is a patch transplanted on top. And when we put it on, there are no blue dots in there. No blue dots means no cells. Blue dots means cells. Here we captured cells migrating into this patch. So if we create the right environment, new blood vessels will form, new cells will form, and the heart will even get better. Last few slides, bottom line. When all else fails, though, people are sick and they need new organs. And so what we've said is, can we build new organs? So the holy grail, in my worldview, is to build a whole heart. But along the way, we're probably going to have to convince the FDA that we can build pieces of the heart as we go along. So we're working on building cardiac valves, cardiac patches, and a whole heart. And I'm going to tell you about that to say a couple things. What does it take to build an organ? I don't think in a very complex way. I think pretty simply. And I said, I don't know, but it seems to me it takes cells. But beating cells in a dish don't make a heart. So it takes a place to put those cells so that they can act like a heart. So it takes a lot of cells, but we already said we can get stem cells from virtually every organ or tissue. But we need a scaffold, a framework for those cells. And we also need them to act like a heart. At the end of the day, if we put them in a scaffold but they don't pump, who cares? Well, scaffold. I always tell the folks in my group, if it were easy, someone else would have done it. But in this case, nature did. Nature has created a perfect scaffold for a heart, for a kidney, for a liver, for a lung. So we said, can we capitalize on what nature has built and use nature's scaffold to build new organs and tissues? Now, one possibility is to recreate in a simple way something that can beat. This is Thomas Eschenhagen has developed all these rings containing beating cells. But I have to tell you, that's not a heart. Or you can build a machine that can filter blood and serve as an artificial liver. Or you can even take a 3D printer these days and print something that looks architecturally kind of like a kidney. But we chose a different way, which is to take an organ and strip all the cells. And when we strip all the cells out, what we're left with is a heart structure framework minus the cells, a liver and gallbladder framework minus the cells, a kidney framework minus the cells, protein comprising the extracellular matrix, that framework. Here's a heart extracellular matrix. And I have to say, Harold Ott, who was a fellow in my lab, is now here at Harvard doing some of this work here. The cool thing about the extracellular matrix is it looks like a heart. See these blood vessels here? There are blood vessels retained in this. And what really surprised us was when we did an experiment to actually look at the strength of these hearts. What we found looking at the left ventricle, remember I told you the heart has to ring? Well, we looked at the left ventricle, And we looked in females and in males, females, males. We did the same thing for kidney, liver, lung, and in every case, the strength of not just the cells, but the underlying structure is stronger in females. And as males age, they catch up with females, but maybe some of the differences we see aren't due to cells, maybe they're due to the structure. Why does that matter? Well, think about it. When a woman gets pregnant, she has to increase the volume of blood in her body 2 to 3 times during that pregnancy, give birth, and immediately her heart has to return to normal. If the heart wasn't capable of pumping all that blood, now I'm making this up, but the data are pretty self-evident that every structure, including the vasculature, is stiffer in females than in males. The good news is it's stronger. The bad news is it may explain why women develop heart failure with preserved ejection fraction, meaning they still can pump as hard, but their hearts can't relax as well. Now, here's a decellularized human heart, and I wanted to show this video to really show you that we can remove all the cells and retain the structure. There's the aortic valve, and if we go through this is a camera stuck inside the heart, and you see it looks white. Normally the heart doesn't look so white. Normally it looks pretty red. But we can go through the whole heart. Here's a decellularized human heart with the blood vessels that you can see. And here we are infusing blood into a human heart, showing that the blood goes back into the blood vessels. And then here is a video of a camera going down the main coronary artery of the human heart, showing that the interior surface of that heart, despite the fact that there are no cells, is intact. One of my cardiology colleagues said, maybe we should be using soap to wash out coronary arteries. Looks beautiful. So we have this structure now with blood vessels, with atria, with ventricles that we think we can use to rebuild an organ from a given individual. This shows actually red cells and green cells that we put into the blood vessel, the arteries and veins of our hearts, to show that we could rebuild the whole vascular supply. Every heart cell has 3 or 4 blood vessels. So we showed that we could rebuild the whole blood supply. And this is a blood vessel in the heart. The blue dots here are cell nuclei. And you can see green and red coming together because the cells migrated in from arteries and veins and rebuilt the vessels. So they know where to go and how to behave. I already showed you an image where we could ask if a patch works. We can transplant a patch on the surface of the heart, and it too grows new blood vessels. And these cells migrate in. And if we look at just a patch of the heart, which comes back to let nature do the work for us, all these blue dots are cells that have migrated in. But you know what? They're not inflammatory cells. If we look at all these cells, none of them, less than 5%, are inflammatory cells. So we can take this structure, transplant it, and it doesn't cause an immune reaction. It's pretty amazing. So we put it all together in a human heart. Well, we've decellularized human heart, and you can see that the human heart goes from having, first of all, look at all the fat on the surface of a human heart, no comment. But muscle here is all washed out. But 3 days later, we still have a structure that looks like a heart. We still have the aorta, the other great vessels. We still have a fully intact heart. And we've said, can we take this heart, and this happens to be a pig heart, but we've done the same thing with human heart, and transplant cells. This took 3 billion human cells transplanted into this heart. And although you can't see much, you can see it's pumping a little bit against 80 millimeters of mercury. Well, I moved to Houston a couple of years ago, and what we learned in Houston is that Houston is not Minnesota. And what I mean by that is it's 100 degrees and there's bacteria growing everywhere. So these started getting contaminated by about day 10 in the lab, reproducibly. It costs about $50,000 to do this experiment. And day 10, it's down the tubes. So last couple of slides, we said, can we let nature do it for us? Let's transplant a decellularized heart heterotopically, put it next to an existing heart, and since the patch recruited all these cells, can the heart recruit all these cells? So we took, this is a pig heart, this is a pig heart. We sewed them together in an animal, in the chest of an animal, and we waited. So when we let nature do that, and then we came back and we took this heart out, this is what we saw. Now, it's not perfect. It's not beating strongly. It's not mature, but that's a heck of a good outcome. We got cells in there. We got blood into the vessels. We got cells beginning to mature. We found vascular cells in the vasculature, muscle cells in the muscle spaces. Now we just got to figure out how to make it better. So, oh yeah, I do have one more slide, and this is, I promise, my last slide. And then there's this. I was walking down the street in Austin, Texas, and I saw this sign. I wish I could trade my heart in for another liver. That way I could drink more and care less. So here's a liver where we did the same thing. And I'm going to show you in real time now putting cells in a liver. Real time, human liver cells in an animal liver. That was it. That's how long it takes. 10 seconds, 30 seconds to put human cells in a liver. And then we let that go for 40 days in the lab. And what we found is that it metabolized drugs as well at 40 days as it did at 2 hours. So it's not science fiction anymore. It's probably becoming science. And I'd like to say that it's easy, but it's not. And for those of you who are students or fellows, I'll just leave you with this. First they ignore you, then they laugh at you, then they fight you, then you win. Thank you.